If it's all right, we'd like to get started. I'd like to introduce Andrea Megerman, Deputy Director of the Prescription Database Monitoring System. She's here to tell us about some of the updates and how we can use it to better care for our patients.
Thank you very much. I am Andrea Megerman, Deputy Director of the Wisconsin Prescription Drug Monitoring Program in the Wisconsin Department of Safety and Professional Services. I was involved in the deployment of our current system back in 2013, and I have been a PDMP administrator since then, and I'm now excited to be working on the development of our new PDMP system, which will be available late at the end of this year or very early next year. We don't have a specific date at this time. So I will be concentrating my discussion on the new system to get you familiar with it, but I will also be giving a little bit of background about PDMP in Wisconsin, talk about some of the legislation that has been passed to change the operations of the PDMP, because a lot of those things were kept in mind as we have been developing the new PDMP system. So here's the agenda for today. Talk about the current state of the system, a little bit of background about the PDMP, go over that legislation that changes the operations of the PDMP, talk about the development of the new system, give you a little bit of a demonstration of the new system. My demonstration today will actually just be some screenshots of the new system, giving some of the highlights, and then talk a little bit about rollout of that new system. So first to talk about the current state of the PDMP. So PDMP is a statewide database that has information about controlled substance prescriptions that are dispensed in the state of Wisconsin. The information is added to the database by pharmacies. So the first step in the process is that pharmacies and other dispensers collect and submit data to the PDMP. They are required by law to do so. There are some pharmacies that have exemptions because they do not dispense any controlled substances, but in general, our compliance rate with pharmacies licensed in the state of Wisconsin has been very high, over 98% compliance, and the little bit of compliance, or the few pharmacies that have been out of compliance have traditionally been new pharmacies that are just recently licensed, and it just takes them a while to get on board, but then they begin submitting as well. So that is the first step. It is all controlled substances, schedules 2 through 5. The next step is that the data is added to the statewide database. So it is cleansed and standardized, it's made more searchable, and then it is made available to authorized users. Authorized users include healthcare professionals who would be looking at patient records before prescribing or dispensing. The information is also made available to law enforcement pursuant to a court order for an open investigation, to government users, also for an investigation. And then de-identified data can be made available to researchers as well to look for trends of abuse, misuse in different parts of the state. So that's just the general process. The data that is in the database is based on prescriber, dispenser, drug, and patient information. The prescriber and dispenser information comes from the DEA number, and from that we get the name and location of those entities. The drug information is based on the NDC number. It also provides information about the name, strength, form, quantity, the dates of prescription and dispensation, and then whether or not there are refills. The patient information is based on last name, first name, date of birth. And then you'll also see some extra information about the patient, including the method of payment, so whether the patient used commercial insurance or cash, or the type of payment that they used, and then also the name of the person picking up the prescription. So that is in red because that is new information that is not currently submitted to the database, but that will be available beginning in April of next year. And that is information that was added because it is feedback that was given to us about that being important to find out if somebody other than the patient picked up the prescription, because that can be a place for diversion at the moment of picking up the prescription. So that is a new piece of information in the database, or that will be, excuse me. So I mentioned that PDMPs are statewide databases. You can see here that almost all states in the country have PDMPs at this point. The Wisconsin PDMP became operational in 2013, and at that time we joined a lot of other states, our surrounding states, that use them already as a tool to prevent prescription drug abuse and diversion. You'll see the only remaining state that does not have a PDMP is Missouri, and it has been blocked legislatively in multiple sessions in Missouri. The main concern has been patient confidentiality. Other states have not had the same concern. Patient confidentiality is of utmost importance, but the PDMP records are protected like other patient healthcare records in the state of Wisconsin, so they are protected records. And Missouri has also found that it is a very useful tool, and they have started to develop a county PDMP in St. Louis County. Other counties in the state will be able to access it as well. So they're trying to get around the fact that the state doesn't have one, and they are implementing a different form of a PDMP because they have found that it is a useful tool to help prevent diversion, misuse, and abuse of prescription drugs. So the history of the Wisconsin PDMP specifically, the legislation goes back to 2009 Act 362, and then the administrative rule writing process began in 2011. The administrative rules went into effect in 2013, so January 1st of 2013, and there the administrative rules were called FAR 18, however that has changed. It is now CSB 4, because the Prescription Drug Monitoring Program is no longer under the purview of the Pharmacy Board, but rather under the Controlled Substances Board. So the data in the database goes back to January 1st of 2013. Later that year, June 1st of 2013, the PDMP became fully operational, and users were able to begin querying the database to look up their patients. And then the last date to look at here is October 1st of 2013, and that's when the PDMP became, the Wisconsin PDMP connected to the PMP Interconnect. It is a data sharing hub, so it allows providers in Wisconsin to get patient records from other states. The initial directive from the board at the time was to begin to share data with our surrounding states first. So we are connected to all of our border states. We are also connected to some other states as well, so the directive was to start with our border states and then sort of expand outward from there. Not all states are connected to the PMP Interconnect, so we are continuing to add states, and it does allow providers to look up patient records from other states at the same time as looking up Wisconsin records. So I will talk a little bit about some of the PDMP legislation that has gone into effect. The first, or that will be going into effect soon. The first is the biennial budget, Act 55. There are a couple of important changes with that. And then the HOPE legislation, several important acts. And I'll be focusing on the ones that have impact on the PDMP and the operations of the PDMP. So first, with the biennial budget, it transferred the oversight of the PDMP from the Pharmacy Board to the Controlled Substances Board. This is important. In the beginning, it was very important to have outreach to pharmacies because pharmacies were the only entities that were required by law to have some sort of interaction with the PDMP, and that interaction was submitting data to the PDMP. And because it was required by law, the Pharmacy Board was able to oversee that and make sure that any pharmacies that were not submitting could be disciplined. However, since then, the focus has moved away from just submitting the data to actually accessing the data. And there are other professions that are involved, and the Act also adds new members to the Controlled Substances Board so that different professions that are involved with PDMP have representation on the board that oversees the PDMP. So the members that were added were the medical examining board chair or delegate, dental examining board representative, and a nursing board representative. So there is still representation from the Pharmacy Board as well. There is also representative from the Department of Justice. So the Controlled Substances Board has a little bit more breadth in being able to oversee the PDMP. It has a variety of functions. To move on to the HOPE legislation, the 2015 Act 266 is the main piece of legislation that has significant changes to the operations of the PDMP. The first is that it increases the data submission frequency from 7 days to 1 business day. So currently, pharmacies are required to submit data to the database within 7 days of dispensing. It then takes about 24 hours for our database vendor to upload the information to the database and make it searchable. So there can be an 8-day lag from the moment of dispensing to the moment that the information is available on the website. That, however, will be changing. The effective date of this act is April 1st of 2017. So instead of being a 7-day submission period, it will move to basically the equivalent of a 24-hour submission period. The law states that it will be by midnight at the end of the next business day. So nothing will be added to the database over the weekend, but business days are defined as days that the Department of Safety and Professional Services is open for business. So Monday through Friday, it's basically a 24-hour reporting. So that's the first thing, making the data more current in the database. The next is a pretty important requirement because it is a requirement for prescribers to review PDMP data prior to issuing a prescription order for a controlled substance. So first thing to note here is that it is for all controlled substances. It is not just for opioids. It is for all controlled substances. A prescriber must review PDMP data. There are a couple of exceptions. Wanted to mention those exceptions here. The first is that the patient is receiving hospice care. The second is the prescription order is for 3 days or less and is not subject to refill. The third is if the drug is lawfully administered to the patient. The fourth is if it's an emergency situation. And then the fifth is if the PDMP system is down or there is some other technical failure. So these are the exceptions that to the requirement to review. In these cases, a prescriber would not have to review the PDMP records prior to prescribing. I want to note that number 3 is currently an exception, currently it corresponds actually with information that is submitted to the database because information is not submitted to the database for prescriptions that are administered directly to the patient. It is for prescriptions that are dispensed. So it's the moment of dispensing that triggers the submission of data to the database, and the fact that a prescriber would not need to review before administering to a patient, that corresponds to the fact that information about administered drugs is not found in the database either. Just to continue with some of the changes to the operations of the PDMP, the next change has to do with allowing law enforcement agencies and prosecutorial units to request PDMP data without a court order. So currently, law enforcement can request PDMP data pursuant to a court order. That will be changing. The new standard is that the law enforcement agency is engaged in an active and specific investigation or prosecution, or they are monitoring a patient as part of a drug court, and that the data that they're seeking is reasonably related to the investigation. So the restrictions on law enforcement data or access of the data are being loosened slightly. All requests by law enforcement are still reviewed by department staff. So law enforcement does not get immediate access to the database. A law enforcement may submit a request. The request is reviewed by department staff for legal sufficiency to make sure that the data sought is related to the investigation, and then it is released. So there is a difference there for healthcare professionals who can access all of the information immediately as it is available, and law enforcement and government who can submit requests and then they are reviewed and the data is then released. One other change to note, we are moving to a new vendor, and in addition to the change going from 7-day to 24-hour reporting, basically, our current vendor takes 24 hours to load data to the database, and our new vendor will be loading as they receive it, so loading the data in real time, so the lag from being possibly 8 days will be reduced to every business day it'll be loaded, but then it'll be loaded continually throughout the day. So that is another change there. So to continue with Act 266, there's one more piece to talk about for Act 266, and it adds access for non-prescriber healthcare and substance abuse professionals. So there are some new roles that are being added to the PDMP. Currently, prescribers, pharmacists, and their delegates have access to PDMP information. However, that will be changing. Here are the new roles. The first role is a medical director role. So this is, the definition of medical director is actually not defined in the law, and it's basically just, it can be for quality assurance purposes, it can be somebody who oversees other prescribers, so it's not specifically defined as one individual within a health system. There are likely going to be multiple people with that role. So, and that is a different type of access, and it will require a different type of account, but it is to oversee or to review the prescribing practices of prescribers under that person's oversight. So that is a different type of role, and it is de-identified data, so it is not patient-specific data. It is more just about prescribing practices for the prescribers. And then the other new roles are for registered nurses. So currently there are a lot of registered nurses who access the PDMP as delegates of prescribers. However, after April 1st of next year, registered nurses will be able to access PDMP data with their own accounts without being linked to a prescriber. There's something to keep in mind when I mention that, however. Delegates will still be available in the new system. Delegates will be linked to prescribers, so for the requirement to review PDMP information, if a prescriber does it, him or herself, or if the delegate that is linked to that prescriber does it, the audit trail will show that that patient was queried, was searched for that particular prescriber. However, registered nurse access will not be linked to a specific prescriber unless it is as a delegate. One other thing about registered nurses, this is very different compared to other states across the country. No other states allow registered nurses to have direct access without being delegates, and because of that, registered nurses under that role will not be able to access interstate data because the interstate data access depends on the laws in the other states. Delegates, however, will be able to do interstate queries. They will be able to do interstate queries. They may or may not have access to all states, and that, once again, depends on the laws in the other states. But if a registered nurse wants to make sure that the audit trail shows the prescriber for whom he or she is querying the database, and if the registered nurse believes that having interstate data access is important, it would probably be recommended that the registered nurse register as a delegate of a provider instead of with an individual access account. So that is a new role type. However, there are some caveats there about whether or not it would be the best process to follow. The other two new roles are for substance abuse counselors and for individuals licensed and certified to treat alcohol and drug abuse. And that's basically just a different license type within the Department of Safety and Professional Services with a specific certificate attached to it. So they would also have access to PDMP information as non-delegate accounts. So that is one more change based on the HOPE legislation. There is one other act that I wanted to talk about, and this one is Act 268, which requires law enforcement to report information to the PDMP, and then requires the PDMP to disseminate the information that is reported to it by law enforcement. So the information that is reported to the PDMP by law enforcement has to do with 4 specific events. The 4 events are a suspected violation of the Controlled Substances Act that involves a prescription drug, a person who is undergoing or underwent an opioid-related overdose, a person who may have died as the result of using a narcotic drug, and then a report of a stolen controlled substance prescription. So this is information that law enforcement submits to the PDMP, and then that information is then disseminated to relevant prescribers of the patient that is involved in the incident. This was added to the legislation to turn the PDMP into a little bit more of a communication tool between areas that do not necessarily have good communication, or maybe there is sometimes good communication, but just to add an extra means of communication between law enforcement and healthcare providers, specifically about overdose events and other violations of the Controlled Substances Act involving prescription drugs. You should note that numbers 2 and 3 are a result of using a narcotic or an opioid, and basically in Wisconsin law, narcotic and opioid are almost interchangeable. So narcotic basically means opioid in Wisconsin. So a suspected opioid overdose, whether it's fatal or non-fatal, would then be reported to the PDMP, and that information would be reported to, would be put on the patient's report in the PDMP, and then also an alert would go out to prescribers who have already prescribed to that patient in question. So this is a new usage of PDMP. There really are no other states in the country that use the PDMP as a communication tool in that same way. And just to show you, this actually went into effect earlier this year, in March of this year. So we have been receiving reports from law enforcement since then. It took a little bit of time for them to understand the law and begin submitting, but since then we have been receiving over 200 reports per month. The majority of those reports are the report of a stolen controlled substance prescription, and that's something that patients will sometimes report to law enforcement that they have had a controlled substance prescription stolen so that they can then get a replacement prescription. And seeing that there is a history of this happening is something that could be important for healthcare providers. The 33% is a suspected violation of the Controlled Substances Act. And then 22% suspected opioid-related overdose, and 4% suspected narcotic-related death. So the overdose information that is submitted to the PDMP is not intended to be complete because it is not linked to death records, and that is something that is housed in the Department of Health Services. This is just as it is reported to PDMP from law enforcement. And the law does not have a specific requirement about the time frame after which they are required to report the information to PDMP. So it is not immediate necessarily. It really is up to the individual law enforcement agency to determine the appropriate time to report that information to PDMP. Yes?
I have a question. The CSA violation, is that the violation of the patient or the violation of the prescriber?
It's a violation of the Controlled Substances Act by an individual, by a patient.
By not the provider.
Right. The main example that we've been seeing of that is possession without prescription, for example. So it is the individual involved, and it is not a violation of the act by a prescriber. Okay, so that actually covers the majority of the relevant changes based on legislation. And I can take other questions if you have questions about the legislative changes. Yes?
Are hospitals or providers supposed to be reporting overdoses?
That is not required in the law. No, it is. No. Yes?
It seems like a violation for law, for the releasing information to law enforcement agencies. How is that? How do you get around that?
Sure. The releasing PDMP information to law enforcement or having law enforcement submit?
It looks like we're giving out information to law enforcement.
So upon request, yes.
Without a court order, that is, it's privileged information. How can we do that?
Sure. It is, the law allows it. So PDMP is not a covered entity under HIPAA, but we do follow a statute, the Wisconsin Healthcare Confidentiality Statute 146.82, and that is what restricted release of the patient information to law enforcement to court order. But because Act 266 changed that, we are then allowed to release it to law enforcement for those specific reasons.
Okay, what about, you said RNs can access the information. Do they need to have some treatment relationship with the individual? Or?
Yes. So all individuals who access the database about a patient must have a relationship with that patient. It's very specific about the different cases. It is being consulted about the treatment of treating the patient directly, or excuse me, I should cite it as it is in the law. It's rendering assistance to the patient, being consulted about treatment for the patient. The patient's life is in danger, and not checking, or let's see, the patient, and not getting that information could put the patient's life in danger. So there are very specific requirements for when a provider can access information about a patient. And once again, it is based on healthcare confidentiality law statute in Wisconsin.
Did you say that you're sending out alerts to providers that
Sure, for some.
What form is the alert sent?
Sure. The information that is submitted by law enforcement is attached to a patient and is then available on the patient report for a provider that looks up that patient going forward. However, to alert current prescribers of that patient that there is an incident that has been reported, an email would go to the provider. The email would not contain any patient information. The email would just alert the provider that a patient has received an alert and that they must log into the PDMP to get that information. Yes?
What's the rationale for including 4 and 5? I mean, I can understand instead of 1, 2, and perhaps 3, but why 4 and 5?
I unfortunately cannot speak to the intent of the legislators who passed the law. I believe that they see all controlled substances as having potential for abuse and diversion, and that's why they were all included. Yes?
Saying that the drug is lawfully administered to the patient is being an exception, is that administered by the provider prescribing, or I deal with nursing home patients who are administered meds by nursing staff. Is that in that exception, or is that different?
So it really is just if the drug is consumed in front of the provider, and that is considered administering. However, if it is a prescription that will be dispensed, it's before the moment of writing the prescription that one would have to check the database. So, yes?
So for many of us, we don't treat chronic pain. We're discharging people from the hospital with a limited supply. I'm thinking most narcotic prescriptions for most of us in the room wouldn't even fall under that. So querying the database wouldn't even necessarily show all of these 3-day or less prescriptions.
So if it's administered, it is not in the database. However, 3-day or less prescriptions that leave the premises with the patient, that are dispensed and leave the patient, that is actually in the database.
So the pharmacy's putting that in, because I'm
Exactly.
not required to.
Yes, the pharmacy that dispenses it is the entity that enters the information into the database.
Even if it's for 2 days.
Yes.
I thought there was an exception for 3 days.
There are no exceptions to, aside from administering directly to the patient, there are no other exceptions for entering the information to the database. So
Well, it's just I don't have to query if it's.
Exactly, yeah.
So as of the spring, that if I'm writing a prescription for 7 days, I'm obligated to check the database.
Yes, yes. I'm sorry.
Do we have to check it for just prescribing birth control or thyroid medication?
So this is for controlled substance prescriptions only. Yes,
So every time the pediatrician refills the Adderall, they're double checking little Johnny's record there.
yes.
Fantastic.
They're delegate.
Their delegate might be doing it for them,
And
exactly.
an RN could be delegate for 12 physicians.
Yes.
And each physician could have 12 delegates.
Exactly, yes.
It says reviewing prior to dispensing, prescribing. Within how much time? Like say, you're doing surgery,
Sure.
and then 5 days later, within how much time are you doing the prescription? So that if you access before, like right immediately before it?
There is no specification about the time period. It just said, the law just says before. It doesn't say how much longer before, and it would just have to be reasonably in a time before, and that's the way that we would have an audit trail of all the prescriptions that are dispensed, and then we would have an audit trail of all the times that a patient's record was accessed, and it just has to be a reasonable amount of time before. It is vague. And I can only discuss the way that it is written in the law, and the law is vague on that point. Yes?
Yeah, I heard that the information will be accessed per physician, by Attorney General's office or some entity. In other words, they could look up a physician and prescribing practices. And if they're all across the board, you know, if they light up like a Christmas tree, is that referred to, where would that case be referred to?
It really depends. It would likely be referred to the medical board, for example. So attorneys in the Department of Safety and Professional Services may access information about prescribers for an investigation of a prescriber. It might be referred to the medical examining board. In other cases, it could potentially be referred to law enforcement for prosecution. It really depends on the type of the case and how they determine it should be referred. But there is a potential for referring to licensing boards and also to law enforcement. And that is, just to clarify, that is something that is currently available as well. So government users of PDMP can request data about dispensers, prescribers, and patients. And once again, their requests are reviewed for lawful sufficiency before they are fulfilled. Yes?
What are the penalties for not querying before you prescribe?
Sure. The penalties have not yet been set, as far as I know. That is something that would be with the medical examining board to determine. So there is a new requirement, as you're very aware, and to help make the requirement to check the PDMP as burden-free as possible, as easy as possible, we are working on deploying a new system. So we have received feedback over the past several years about the current system, and we're developing a new system to try to address some of the issues with the current system. So I will go over the new system for a few minutes. Like I said, I only have screenshots today. It's currently in development, and our test site is constantly changing, so it's easiest to have reliable information based on the screenshots. But the goals of the project, the development of the ePDMP, the enhanced PDMP, are to maximize the program's value-added clinical workflow integrations, to maximize the data quality capabilities, and then to also maximize public health and public safety use of the PDMP. So the clinical workflow is trying to make the database as easy to access as possible, and then to make the information in the patient report as easily consumable as possible, so that the most important data is more readily available. Data quality, making sure that patient matching is as accurate as possible, and then public health and public safety use, using the PDMP as a communication tool between different groups of individuals, and then also making the de-identified data a little bit more available to researchers as well. So those are the goals of the PDMP system, the ePDMP. The first thing is that it's a more modern website. It should look a little bit more like other modern websites that you interact with regularly. The place to go to access your account is very prominent on the screen, username, password, and if you don't yet have an account, there's a very easy link to register. So that is the first thing, making everything more apparent on the first page. One other thing to note is the responsive design of the website. So we recognize that not everybody will be standing at a desktop computer. Here it renders nicely if it's on a tablet. It does even render nicely on a phone. Phones are still a little bit small, but it can be, it's a little bit more accessible on a mobile device than the current system because of the responsive design. Registration. So even current users of the PDMP will have to re-register. And to make that as easy as possible, it's a somewhat automated registration process. So selecting healthcare professional, entering last name, last four of the social, and date of birth, clicking, and then license number, license type, clicking lookup, actually sends a web service call to the Department of Safety and Professional Services to get information from the licensing database in our department, so that a lot of the information is then pre-populated for you, and it verifies your identity based on that information. So once it's pre-populated, you then create, you create a username, password, click submit, and then receive an email to activate your account. So it should be a pretty seamless process, a pretty easy process to re-register for an account. Once you have your username and password, this is what the interface will look like. To get a patient report, go to patient report, enter last name, first name, date of birth. If you wish to query other states, you can do so on the same screen instead of going to a separate query screen, which is what the current system makes users do. Select other states. You can select multiple states. Wisconsin is selected by default. Clicking submit.
You do all states at the same time?
There is no way to click on a word that says all states. So if you wanted to select all of the states, you would have to select them individually. The reason that we do that is because for each state that is added, it can slow down the query a little bit. And we only have insight into our own data. We don't necessarily have insight into the data in the other states. So selecting lots of states has a higher likelihood for returning false results about a patient. The likelihood that John Smith with a specific date of birth exists in this state and another state is higher. So the results, we cannot be as confident about the results if more states are returned. And then it does take a little bit longer because it's basically the slowest database slows down in the other states, slows down the results to be returned for this query. So yes, it is possible, but there isn't a way to always select all other states for all queries. Yes?
When does this go into effect? When do we need to re-register?
Sure. So the new system will be going live toward the end of this year or shortly after the new year. We unfortunately do not have a specific date at this time, but it will be no later than mid-January. And all licensees of the state and all current users of the PDMP will receive multiple communications about the new system going live. Yes?
Where is the data you have right now for PDMP?
Sure. About 4,500 on average.
How many is it going to jump to where we all have to query it all the time?
It will be jumping, and we unfortunately have no way to...
On a factor of 50. Are you sure your database can handle that?
Yes. It's something that we are developing with the knowledge that it is a requirement. So our database vendor has assured us that it will be able to handle the larger volume. Yes?
One of the exceptions was that if there was some type of technical failure, how is that going to be done?
Sure. There is, so the law actually does state if there is a technical failure and you then report it to the department, to the Controlled Substances Board. So there will be a mechanism on the website to report failures to the board if necessary.
What kind of time lag is a technical failure? So if we wait a minute, do we call a technical failure and just skip it then? Seriously, is that going to be, what kind of lag is going to be considered appropriate?
That is up to professional judgment. There is nothing written into the law about what actually constitutes a technical failure. If you are encountering a problem at the same time as somebody else and it's a generalized problem, it will be pretty evident. If it's a problem that just one person is having and an associate nearby is accessing without an issue, it would be harder to prove that it's a technical problem. But the requirement does, the system is required to be up 24/7, so there is zero downtime for the PDMP. So if you do encounter a technical failure, we should also have documentation that there was a failure at the time, but as I mentioned, they have assured us that it will be up 24/7 and able to handle the larger volume. So. Yes.
Looking at the effectiveness of this, in other words, does this work in this state or elsewhere in terms of outcome?
Yes, that's a really good point. We recently did one survey of a random selection of users from the current system, and the results of that were in a report that was made from the Controlled Substances Board. The Controlled Substances Board is required by law, it's one of the other legislative changes, they're required by law to do quarterly reports looking at the data in the database and some of the outcomes of the information that the database the data can provide. So looking at prescribing practices, but then also looking at user satisfaction with the PDMP. So there will be reports generated on a quarterly basis, and it is a requirement in the legislation to see if the PDMP is an effective tool. Yes?
So the PDMP is trying to integrate with Epic right now. Are they going to be integrating with Cerner as well? And when can we anticipate something like that?
Sure. So we recognize that to help providers access the information, it would be useful to have an EHR integration. We are currently working with different health systems who use different EHR platforms to pilot some EHR integration possibilities, and it really is system driven. So if a healthcare system is interested in creating an EHR integration, we are following up on the requests. So let's see, we have been in discussions with healthcare systems that use Epic. We have actually had some discussions with healthcare systems that use Cerner as well, and it really depends on the healthcare system reaching out to the EHR platform to have them sort of build the integration that is appropriate. I will say that Cerner does have, there are two different EHR integration pathways. One is through a hub, and that is actually a current integration that is active with a couple of health systems in the state right now. And Cerner has a close relationship with that particular hub, so it's likely that they would be able to continue offering a PDMP EHR integration through that hub. Then we are also looking at a PDMP EHR integration, a direct API integration that does not use the hub, and that is sort of the pathway that Epic is currently looking at. But we recognize that having this integration is very important and useful, specifically with a mandatory use requirement. So we're hoping to work with as many entities as possible to make it possible. So, yes?
Do you have an estimate right now from when I start the query to I'm done with it, how much time it will take?
Sure. Okay, so let me go back one screen. So from the time you log in or from the time you are already logged in, I guess clicking here, entering that name, the last name, first name, last name, date of birth, and clicking submit, it usually appears within a couple of seconds. From there, the information that is on the report, it will be a little bit different in that the alerts would appear across the top. So if this patient had no alerts, there would be no red button. So it's something to draw your attention immediately. Is there something about this patient that might concern me? A visual representation of the patient's prescription history with the patient address, the pharmacy address, the prescriber address. This is really just based on one record, so it's not particularly representative of what it could look like. And it allows you to see sort of distance between address and providers. And then at the bottom of the screen, so one other piece of information in the screen specifically about opioid prescriptions showing the morphine milligram equivalent. This is just a mock-up, so it's not particularly meaningful, but it shows a threshold, and you can see if a patient is above a threshold or below a threshold for opioid prescriptions, and whether or not there are overlaps with opioids and benzos. So once again, a visual representation of overlapping prescriptions, and then at the bottom of the screen, the actual grid that one currently sees in the database with all prescription records. So it comes up within a matter of seconds, and then it's a question of the part of the record that is of most importance, and it's hopefully presented in a way that brings some more of the pertinent information to your attention more readily. So it's a pretty quick process. Yes?
Can institutions control the logins and passwords
for the providers? Can it be done at an organizational level that IT can control all the usernames and have them match their current usernames for other applications, such that they're all the same, and such that you could use a single sign-on technology to get into the database?
So the single sign-on technology would be with an EHR integration, and it would be a button within the EHR that would allow one to see PDMP data. The way registration is set up is it is licensee based, so it is based on an individual. The individual can create the username and password, so if there is a specific username that individual uses to log into other applications for the health system, they can use that same username. And it would be up to healthcare system administration to determine whether or not they are going to suggest a specific username password type combination, or whether or not they will try to implement some sort of assistance in registering. That's not something that the department can.
But each provider, one by one, needs to do their own.
There would be, yes, an individual registration. Is there another question in back? No? A couple of other things to make the information more readily available. In addition to searching for a specific patient, there would be a way to obtain a patient panel. So clicking on that would show the patients to whom a prescriber has prescribed within the past 90 days in order of most recent at the top. And these are all sortable fields. And this gives a very quick snapshot of the recent patients to whom this provider has prescribed. Seeing the date of the last prescription, the current morphine milligram equivalent, whether or not the morphine milligram equivalent is trending up or down, and then whether or not the patient has any alerts active in the system, being able to click on that to see what the alert actually is, and then also getting one-click access to the patient report instead of entering first name, last name, date of birth. So if it is somebody to whom you have prescribed recently, that individual would appear in this list, and you could just get one-click access to that patient report. And then the final section here has to do with prescribing practice metrics, and this is something that is available to prescribers only, and it's a self-query tool to be able to see information about average number of opioid prescriptions per day, average number of, this is once again just a mock-up and it's actually a little bit out of order. So the average number of opioid prescriptions per day and average number of doses per opioid prescription. Average number of stimulant prescriptions per day, average number of doses per stimulant prescription, etc. And then average opioid patient morphine milligram equivalent. So this is something that allows a prescriber to review his or her prescribing practices. In the first phase, it really will just be a tick on a bar to show you this is the volume. However, a second phase will show, with color coding, how that falls as far as percentages with others in the same specialty. So registration does require a specialty for prescribers, and this would be a place where that specialty would be used to look at how a prescriber compares with others in the same specialty. This information is similar to the information that would also be made available to people with the medical director role about the prescribers under their oversight. So just to look at a couple of the other analytics, there would be information about prescriptions by payment type based on the patient population, and then some other analytics, patients with active concerning history alerts, patients who meet doctor shopping thresholds, patients who meet pharmacy shopping thresholds, patients with law enforcement alerts, and then the distance traveled by patients. At the bottom of the screen, there would be the traditional prescription history grid of all prescriptions prescribed by that provider. Okay. One other thing that I just wanted to go over quickly on the patient report has to do with the alerts. So I mentioned the alerts, and some of the alerts come from law enforcement. So they would appear there. Clicking on the alert allows you to read more details about the law enforcement agency that entered the information. Other alerts are user-generated. So this one is an example of a pain agreement, or actually it'll be a treatment agreement alert. And if a patient has a treatment agreement with a provider, the provider can enter that information here by clicking the box and then adding comments, the relevant information, and clicking submit. So that can be entered and made available to others who might be looking at the patient. And then the third type of alert has to do with a concerning history alert, and those are all based on analytics. So it looks at morphine milligram equivalents, overlapping benzodiazepine and opioid prescriptions, meeting certain thresholds of doctor shopping or pharmacy hopping, a certain number of prescribers within a set time period, or a certain number of pharmacies within a time period. So those are all analytics or data-driven alerts. And once again, if a patient doesn't have any alerts, doesn't meet any of those thresholds, there would be no red boxes up at the top of the patient report. So I believe I've gone through the majority of the new system. It is about 1 o'clock, so I can take a couple more questions if you have any more questions. Yes?
I want to make a comment. Why don't we just even add a prescription capabilities into this website, so all Schedule 2 to 5 drugs can only be prescribed through that system?
So that's a really interesting point, and that is something that with the EHR integration might be coming. So an idea that has been implemented in other states or that is being discussed is that if there is, and this is something that a health system could determine, that if there is an EHR integration and a provider starts to enter a prescription in that EHR for a controlled substance prescription, there would be some sort of block that would prevent the provider from moving forward with writing the prescription until they look at the PDMP. So that is something that is technologically possible. It is not without precedent. There are other states that have implemented similar things, but it really would be more up to the EHR to do that instead of, so it really has to do with integrating PDMP into EHRs more than turning the PDMP into sort of a prescription tool. So it's a really good, it's a good idea. And it's something for health systems to consider.
Is the query satisfied just by opening the chart? I mean, if you've queried recently, you don't want to look at the same alert again. You just get to that first page and you're done, right?
So basically the audit trail shows whether or not the patient's report was accessed before the moment of the prescription being dispensed. We will not be in a room with you to see what your review actually is. The law just requires a review of the patient
It
report.
does work that you search the patient and then the first thing that comes up is that report, right?
Yes. Yeah. So the last details that I have here are about the deployment of the new system. As I mentioned, you will be getting communications, multiple communications hopefully, about when it will be going live, details with links about how to register. There will be a new web address that will be included as well. And then the new roles that I mentioned, we are building them now with the building of the new system. However, because the law doesn't go into effect until April, some of those new roles will not be available until April. Delegates, however, will be available before April. And then more details about EHR integration are forthcoming or are available upon request. So there are different integration pathways, and we recognize that integration is quite important. So we are willing to pursue integration efforts with as many health systems as possible. Here's some contact information. I'm Andrea Magermans. Chad Zadrazil was unfortunately unable to make it today, but we worked together, and that telephone number, that email address will contact either one of us, or we'll both respond. So I thank you very much for your time, and if you have other questions, you're welcome to ask them. So thank you very much.